Welcome to NST 222, Study Session 12, Shock. Introduction. Shock is described as a life-threatening condition which is due to a variety of underlying causes. A state of shock describes the body's response to inadequate tissue perfusion. The outcome of shock is clinically unpredictable. It is therefore important that you, as a nursing student, should understand the mechanism of shock in order to recognize early signs and provide the necessary interventions that will mitigate its progression and complications. In this study session, the different types of shock and the nursing interventions would be discussed. Learning outcomes. At the end of this study session, you should be able to define shock, highlight and explain the different stages of shock, explain general management strategies in shock. Shock. Shock can be defined as a condition in which tissue perfusion is inadequate to deliver oxygen and nutrients to support vital organs and cellular function. Shock is not a disease entity, but a condition resulting from different causes. Classification of shock. Shock based on the underlying causes. They include cardiogenic, hypovolemic, anaphylactic, neurogenic, and septic shock. It is important to note that anaphylactic, neurogenic, and septic shock are collectively classified as distributive shock. The mnemonic chants may be a useful memory trick to remember the types of shock. CHANS. C equals to cardiogenic, H hypovolemic, A anaphylactic, N neurogenic, S septic. Let us discuss the different types of shock. Cardiogenic shock. This occurs due to pump failure, whereby the heart cannot contract effectively to pump and supply blood and oxygen to the tissues, resulting in hypotension, cellular hypoxia, and inadequate tissue perfusion. Cardiogenic shock occurs more commonly in patients with diseases of the heart, such as myocardial infarction, MI. Other causes of cardiogenic shock are related to conditions that stress the myocardium, e.g., severe hypoxemia, acidosis, hypoglycemia, and hypocalcemia, as well as conditions that result in ineffective myocardial function, e.g., cardiomyopathies, valvular damage, and arrhythmias. Clinical manifestations. Hypotension from reduced cardiac output causes a release of catecholamine, epinephrine, and norepinephrine, which cause vasoconstriction and further increase in workload on the heart and further decrease in cardiac output. The overworked heart becomes congested and blood backs up in the pulmonary system, resulting in congestive heart failure. Multiple organ failure and possible death due to poor cellular perfusion ensue. Other clinical manifestations are as occurs in hypovolemic shock, cool climbing skin, weak and tread pulses, tachycardia, decreased urinary output, anxiety, shortness of breath, hypotension. Nursing management of cardiogenic shock. The following steps are taken by nurses in the management of cardiogenic shock. Preventing cardiogenic shock. Monitoring hemodynamic status. Administer fluids and medications. Enhance safety and comfort. 1. Preventing cardiogenic shock. Identify early signs in patients who are at risk and promote adequate perfusion of the heart muscle, thereby decreasing cardiac workload. When cardiogenic shock is present, nursing interventions include steps to prevent progressive development of shock. Attempts should be made to restore adequate cardiac function and tissue perfusion. 2. Monitoring hemodynamic status. A major role of the nurse is to monitor the patient's hemodynamic and cardiac status. Changes in hemodynamic, cardiac, pulmonary, and renal status and laboratory values are documented and reported promptly. Monitor closely the oxygenation status by pulse oximetry. 3. Administer fluids and medications. Fluid overload and pulmonary edema are risk factors and should be avoided. This is because of ineffective cardiac function and accumulation of blood and fluid in the pulmonary tissues. 4. Enhance safety and comfort. The nurse should take an active role in safeguarding the patient, enhancing comfort, and reducing anxiety. This includes administering medication to relieve chest pain, preventing infection at the multiple arterial and venous line insertion sites, maintaining the skin integrity, and preventing skin breakdown. This is achieved through regular repositioning the skin and monitoring of respiratory and renal function. 1. Hypovolemic shock. Hypovolemic shock occurs when there is a reduction in a patient's circulating blood volume, specifically intravascular volume. It is the most common type of shock. As we learned in the previous study session, water constitutes a significant percent of the body weight, and it is distributed into two major compartments. Hypovolemic shock occurs when there is a reduction in intravascular volume by 15% to 25%, which represents a loss of 750 to 1,500 ml of blood in a 70 kg person. Absolute or relative hypovolemia leads to shock. Absolute hypovolemia occurs from fluid losses such as hemorrhage, vomiting, diarrhea, etc. While relative hypovolemia results from fluid sheaths called third spacing or volume leakage from vascular space into the interstitial space due to increased capillary permeability. Examples of such conditions are burn injury and sepsis. It should be noted that the clinical manifestations in both relative and absolute hypovolemia are similar. This classification is based on the percentage of fluid loss. For example, mild hypovolemic shock describes less than 20% loss of circulating volume. Moderate hypovolemic shock occurs with between 20% to 40% loss. Severe shock occurs in over 40% loss of circulating volume. Kelly, 2005. Signs and symptoms of hypovolemic shock. Early signs. These include subtle changes in vital signs which may be missed, such as mild tachycardia, mild hypotension, Typonic less than 80 mmHg or 40 mmHg, below declined normal reading. Other signs indicating severe compromise include anxiety, restlessness, cold clammy skin, severe tachycardia if not corrected, arrhythmias and chest pain. In severe cases, patient develops changes in sensorium. Nursing management of hypovolemic shock. The focus of nursing is to prevent hypovolemic shock through close monitoring of patients at risk for fluid volume deficit. Nurses should also assist with fluid replacement before intravascular volume is depleted. Early identification of the signs and restoration of intravascular volume is essential. General nursing measures include ensuring safe administration of prescribed fluids and medications and documenting their administration and effects. Another important nursing role is monitoring for signs of complications and side effects of treatment and reporting these signs early in treatment. Distributive shock. Distributive shock consists of three forms of shock with similar pathophysiological processes. They include neurogenic shock, anaphylactic shock, septic shock. Each of these categories would be discussed below. A. Neurogenic shock. Neurogenic shock is a subcategory of distributive shock. It occurs due to injury to the nerves of the autonomic nervous system, causing a relaxation of the walls of the blood vessels, vasodilation, and slowing of the heart rate, bradycardia. Neurogenic shock is a hemodynamic consequence of spinal cord injury and/or disease of the 5 thoracic vertebrae (T5) with a disruption in autonomic nervous system control, resulting in decreased vascular tone, hypotension, bradycardia, and inadequate tissue perfusion. It is also referred to as circulatory shock because the body is unable to adjust to the impaired vascular tone, which results in massive pooling in the blood vessels, hypoperfusion, and impaired cellular metabolism. Risk factors for neurogenic shock. Trauma to the spinal cord, penetrating of blunt injury, regional anesthesia, and depression of the vasomotor center in the medulla by drugs which affect the autonomic nervous system. Example: opioids, benzodiazepines. Clinical manifestation: flaccid paralysis, absence of reflexes, hypotension, bradycardia, paralytic ileus, and hypothermia due to loss of temperature regulation. Other forms of distributive shock are septic and anaphylactic shock. B. Septic shock. This is consequence of systemic infection. It is systemic inflammatory response to a documented or suspected infection with hypotension despite fluid resuscitation. Risk factors include immunosuppressive conditions, HIV/AIDS, which weakens the immune system, extremes of age greater than 1 and less than 65 years, malnourishment, chronic illness, diabetes mellitus, leukemia, etc., invasive procedures, indwelling urethral catheterization. In this case, systemic infection results in exaggerated inflammatory response, coagulation and decreased fibrinolysis and release of toxins. See previous lecture on inflammatory response. C. Anaphylactic shock. Anaphylactic shock is a life-threatening event resulting from a widespread allergic reaction to a sensitizing substance. See study section on hypersensitivity reaction. Stages of shock. Shock is believed to progress along a continuum. One way to understand the physiologic responses and subsequent clinical signs and symptoms is to divide the continuum into separate stages. 1. Pre-shock. Compensated non-progressive shock. 2. Shock. Uncompensated. 3. Irreversible shock and end organ damage. Pre-shock. Compensated non-progressive shock. Pathophysiology. In pre-shock or the compensatory stage of shock, the BP often remains within normal limits. Vasoconstriction, increased heart rate, and increased contractility of the heart contribute to maintaining adequate CO and SVR. This results from stimulation of the sympathetic nervous system and subsequent release of catecholamines, epinephrine, and norepinephrine. Patients display the often described fight or flight response. The body shunts blood from organs such as the skin, kidneys, and gastrointestinal GI tract to the brain and heart to ensure adequate blood supply to these vital organs. As a result, the skin is cool and clammy, bowel sounds are hypoactive, and urine output decreases. Adult patients can often compensate for up to a 10% total volume loss through normal homeostatic mechanisms. Conversely, patients who have other medical problems or who take certain medications may have a diminished ability to compensate. Clinical manifestations and assessment. Despite a near normal BP, the patient may show other clinical signs indicating inadequate organ perfusion. Tachycardia, peripheral vasoconstriction, and anxiety are common. Medical and nursing management. At this stage, treatment is directed toward identifying the cause of shock, correcting the underlying disorder, and initiating aggressive measures aimed at supporting the body's compensatory mechanisms. Because compensation cannot be maintained indefinitely, measures such as fluid replacement and medication therapy must be initiated to maintain an adequate BP and re-establish and maintain adequate tissue perfusion. Early intervention along the continuum of shock is the key to improving the patient's prognosis. Therefore, the nurse must assess the patient at risk for shock systematically to recognize the subtle clinical signs of the compensatory stage before the patient progresses to uncompensated shock. The role of the nurse at this stage is to monitor the patient's hemodynamic status and promptly report deviations to the provider to assist in identifying and treating the underlying disorder by continuous in-depth assessment of the patient, to administer prescribed fluids and medications, and to promote patient safety. In assessing tissue perfusion, the nurse specifically observes for changes in level of consciousness, vital signs, urinary output, skin, and laboratory values. Constant reassessment is warranted at this stage. Nurses should try to maintain a calm environment both for patients and family's sake, and also ensure that assessment and interventions are rapid and ongoing. Providing brief explanations about the diagnostic and treatment procedures, supporting the patients during these procedures, and providing information about their outcomes reduces stress, and thus promotes the patient's physical and mental well-being. Speaking in calm, reassuring voice, and using gentle touch also help ease the patient's concerns. Shock, uncompensated. In shock, the patient loses the ability to compensate for the insult, infection, or injury. It is during this stage that clinical signs become more obvious. Pathophysiology. The heart and kidneys are among the first organs to show signs of dysfunction. The body's inability to meet increased oxygen requirements produces ischemia, and biochemical mediators cause myocardial depression. This leads to failure of the cardiac pump, even if the underlying cause of the shock is not of cardiac origin. The systemic impact of hypotension and thus hypoperfusion on the kidneys results in inserted and urine output should be measured vigilantly. Medical and nursing management. Early aggressive interventions are essential to the survival of patients in shock. Therefore, identifying patients who may be in shock and reporting subtle changes in assessment are imperative. Patients in shock are often cared for in the intensive care ICU setting to facilitate close monitoring. Hemodynamic monitoring, electrocardiographic ECG monitoring, arterial blood gases, ABGs, serum electrolyte levels, physical and mental status changes, rapid and frequent administration of various prescribed medications and fluids, strict measurement of intake and output, high and low, and possibly interventions with supportive technologies such as mechanical ventilation, dialysis, and intra-aortic balloon pump. Nursing care of patients in shock requires expertise in assessing and understanding shock and the significance of changes in assessment data. Specific management of shock depends on the type of shock and its underlying cause, but in general, care is aimed at achieving the following goals: optimizing intravascular volume, supporting the pumping action of the heart, improving the competence of the vascular system, supporting the respiratory system, continual assessment and reassessment of the body's response to shock, involving the patients and family in care, particularly in end-of-life decisions. End organ damage, irreversible. Pathophysiology. If tissue perfusion is not restored, irreversible and organ damage ensues. This represents the point along the shock continuum at which organ damage is so severe that the patient does not respond to treatment and cannot survive. For example, despite treatment, BP remains low. Renal and liver failure, compounded by the release of necrotic tissue toxins, creates an overwhelming metabolic acidosis. Anaerobic metabolism contributes to a worsening lactic acidosis. Respiratory system failure prevents adequate oxygenation and ventilation despite mechanical ventilator support, and the cardiovascular system is ineffective in maintaining an adequate mean arterial pressure. MAP. MAP equals to bracket 2 times diastolic pressure plus systolic pressure 3 for tissue perfusion. Multiple organ dysfunctions progressing to complete organ failure has occurred and death is imminent. Multiple organ dysfunctions can occur as a progression along the shock continuum or as a syndrome unto itself. Medical and nursing management. Specific therapies in this stage are usually the same as for shock, although the patients may have progressed from shock to irreversible end organ damage. The judgment that the shock is irreversible can be made only retrospectively on the basis of the patient's failure to respond to treatment. As in shock, the nurse focuses on carrying out prescribed treatment, monitoring the patient, preventing complications, protecting the patient from injury, and providing comfort. Offering brief explanations to the patients about what is happening is essential, even if there is no certainty that the patient hears or understands what is being said. Simple comfort measures, including reassuring touches, should continue to be provided despite the patient's non-responsiveness to verbal stimuli. As it becomes obvious that the patient is unlikely to survive, the family must be informed about the prognosis and likely outcome. Opportunities should be provided throughout the patient's care for the family to see, touch, and talk to the patient. Close family friends or spiritual advisors may be of comfort to the family members in dealing with the inevitable death of their loved one. Whenever possible, the patient's family should be approached regarding any living wills, advance directives, or other written or verbal wishes the patient may have shared in the event that he or she became unable to participate in end-of-life decisions. In some cases, ethics committees may assist families and healthcare teams in making difficult decisions. General management strategies in shock. Management in all types and all phases of shock includes the following: fluid replacement to restore intravascular volume, vasoactive medications to restore vasomotor tone and improve cardiac function, nutritional support to address the metabolic requirements that are often dramatically increased in shock. Fluid replacement. The fluids administered vary but may include crystalloids, electrolyte solutions that move freely between intravascular and interstitial spaces, colloids, large molecule IV solutions, and blood components. The best fluid to treat shock remains controversial. In emergencies, the best fluid is often the fluid that is readily available. Fluid resuscitation should be initiated early in shock to maximize intravascular volume. Both crystalloids, e.g., saline and lactated ringers, LR solution, and colloids, e.g., albumin, can be administered to restore intravascular volume. There are different camps regarding whether crystalloids or colloids should be used. Blood should be given for hypovolemic shock due to trauma and/or hemorrhage. Vasoactive medication therapy. Vasoactive medications can be used in all forms of shock to improve the patient's hemodynamic stability when fluid therapy alone cannot maintain adequate mass. Different medications work on different aspects of CO, and specific medications are selected depending on the underlying cause. Although most of the medications have several effects, these medications are used for the following: 1. Increase strength of myocardial contractility. 2. Regulate the heart rate. 3. Reduce myocardial resistance. 4. Initiate vasoconstriction. Nutritional energy requirements are then met by breaking down lean body mass. In this catabolic process, skeletal muscle mass is broken down even when the patient has large stores of fat or adipose tissue. Loss of skeletal muscle greatly prolongs the patient's recovery time. Parenteral or enteral nutritional support should be initiated as soon as possible, with some form of enteral nutrition always administered. Respiratory support. Oxygen is administered to increase the amount of oxygen carried by available hemoglobin in the blood. A patient who is confused may feel apprehensive with an oxygen mask or cannula in place, and frequent explanations about the need for the masks may reduce some of the patient's fear and anxiety. Frequent assessment of the respiratory status is warranted since many patients with severe shock will require ventilator support. Continuous oxygen saturation monitoring is expected. Summary. In this study session, you have learned that shock can be defined as a condition in which tissue perfusion is inadequate to deliver oxygen and nutrients to support vital organs and cellular function. 2. Shock based on the underlying causes. They include cardiogenic, hypovolemic, anaphylactic, neurogenic, and septic shock. 3. Cardiogenic shock occurs due to pump failure, whereby the heart cannot contract effectively to pump and supply blood and oxygen to the tissues, resulting in hypotension, cellular hypoxia, and inadequate tissue perfusion. 4. Shock is believed to progress along a continuum. One way to understand the physiologic responses and subsequent clinical signs and symptoms is to divide the continuum into separate stages. Compensated, non-progressive shock, pre-shock. Uncompensated shock, irreversible shock, and end organ damage. 5. Management in all types and all phases of shock include the following: fluid replacement to restore intravascular volume, vasoactive medications to restore vasomotor tone and improve cardiac function, nutritional support to address the metabolic requirements that are often dramatically increased in shock. End of study session 12. Thanks for listening.